Hello guys, welcome to the Medicine Fun Facts channel. I am Dr. Regina Okonagbulu and today we'll be discussing interpretation of cardiac myocardial perfusion imaging, also known as MPI. So what is MPI? It's a nuclear stress test that assesses the vasodilatory reserve of the coronary arteries. A quick reminder here. During exercise or stress, the coronary arteries are expected to dilate to meet the metabolic demands of the body. During rest, the heart can supply its blood supply. The heart can supply blood to itself, even up to 90% stenosis. Even with 90% stenosis. The ability to provide the maximum flow during stress, which is known as coronary flow reserve, is diminished with approximately 50% stenosis. And this test, MPI, is pivoted on this property. Extraction of the tracer from the coronary vasculature into the myocardium is proportional to coronary blood flow. Comparison is then made with changes in distribution of the tracer during stress and rest, and this helps with the diagnosis of infarction or ischemia that has been induced by the medical personnel. Reminder that this test again is a functional test, it's not an anatomical test, and the stressor can be physical or pharmacological. I'm sure that begs the next question. What is a tracer? It's a radiopharmaceutical substance that can be imaged. It's a radioisotope that's linked to a carrier molecule, and this carrier molecule directs it to an area of interest via a specific molecular pathway. The radioisotope in the body would decay by either a gamma ray emission, which is detected by the SPECT camera, the single photon emission computerized tomography camera, but this is a bit different from the positron emission, which is detectable by the PET camera. This is not the subject of today's talk. It is all under nuclear cardiology. So what are those single photon emitting radiopharmaceuticals? Examples are thallium-201 labeled with thallose chloride or thallium chloride. This has a half-life of 73 hours. Then you also have technetium-99m, which is labeled with Sestamibi. It's also called MIBI, with a half-life of 5.4 hours. Then you have technetium-99m that's labeled with tetrophosphine, sold as MyoView. This has a half-life of about 6 hours. So why is MIBI more popular? That's the Sestamibi, technetium Sestamibi, because it has a shorter half-life. And then it has a slower removal from cardiac tissue, and this allows for better image quality. Also, it has a higher sensitivity. However, diagnostic accuracy may not be necessarily superior to the others. And it's also said that technetium in any combination, whether as Sestamibi or tetrophosphine, has higher energy, less attenuation, and less scatter of photons. And these are properties that delights the hearts of the nuclear cardiologist and nuclear radiologist. So why do we do this test? When there is a suspicion of coronary artery disease, when we need to identify inducible ischemia in a patient with intermediate or low risk of a major cardiovascular event. But please, this shouldn't be done with ongoing symptoms. When we need to identify the extent of inducible ischemia in a pharmacologically stabilized patient, when we need to identify the hemodynamic significance of stenosis in this patient, or we need to measure the baseline LV function, or there is new onset left bundle branch block, or there's a patient with a paced ventricular rhythm and we don't know what is going on underneath all of that. We also do this test when we have new or worsening symptoms suggestive of CAD, when we need to identify the extent of stenosis when ECG is not diagnostic, that may sound repetitive, when we need to look at the regional or global LV function after revascularization, If a patient is in heart failure and we want to rule out a reversible cause and symptoms are stable somewhat, we can subject the patient to this test. When we think that this patient has dyspnea of probable cardiac origin, and it's suggested that in a one-time review of prior CABG, for instance, 5 years post, we can do just the one-time MPI. A patient who's had PCI 2 years post, we can do just the one-time PCI also. So a midway summary for the indications would be to establish diagnosis, to risk stratify with known CAD, to look at myocardial viability before intervention, assessment of efficacy of therapy, and any other intervention. We may also have some special reasons why we do this test. This could be to assess the hemodynamic significance of in a condition like the anomalous coronary arteries or muscle bridging in some patients, to assess the hemodynamic significance of aneurysms in a patient with Kawasaki's disease, to assess risk in asymptomatic patients with CAD, and to assess the presence and extent of CAD in patients with arrhythmias. So how is this done? So this may be a 2-day or 1-day protocol. And in a 2-day protocol, each stage, whether it's the rest protocol or the stress protocol, is done on each is done on day 1 or day 2. And if it's a 1-day protocol, we do the rest protocol and the stress protocol, all of it on the same day. Now for the rest protocols, the Sestamibi, which is a tracer, is injected and patient pictures are taken with a gamma camera. In a stress protocol, physical stress or pharmacological stress with either dipyridamole, adenosine, dobutamine, or regetnosine is given before the injection of the Sestamibi. This is followed by another set of stress pictures from the gamma camera. So let's look at a composite rest stress protocol. Now, please remember that this can also be stress rest. So let us say we had a 1-day protocol. The patient came in for a 1-day protocol. We'll start with the rest, if that's what we wanted to do in our hospital. Inject the tracer, wait for some time, take rest pictures, and then we now go for the stress, however we want to do it, physical or pharmacological. Inject the tracer when we are satisfied, and wait for another 45 minutes or thereabout and take stress pictures, and this will be reviewed later by the medical personnel. If we needed to do a 2-day protocol, we could start with a rest or stress, whatever, but this one is rest here. We would inject the tracer, patient takes pictures and goes home or goes back to the ward, and then comes back the next day. Patient is stressed, tracer is also injected and pictures are taken. So that gives a flow. So it's important to note that if we're doing just the 1-day stress rest or rest stress, the two protocols are separated by 3 to 4 hours. The first tracer dose is normally lower than the second tracer dose. In fact, the guidelines say that the second tracer dose should be 3 times the first tracer dose, so kind of swamp the first dose. And it doesn't matter if this is stress rest or rest stress. The 2-day protocols, it's said to be better for larger patients, and the bigger doses can be done, like the 400 megabecquerel stress and rest. Well, there's no swamping in this one, and it's debatable, but some quarters say you have better images. The drawback for the 2-day protocol is that it's a bit cumbersome for the patients, particularly patients who are not in the hospital with you. But let's just remember that in the 1-day protocol, the patient has to do a long wait in the department. Now, newer updates of these protocols. It's said that we can get away with just a stress panel, protocol. After all, if the stress panel is normal, then it shows that there's good, myocardial perfusion. So what do we need the rest for? So that is the argument. And currently, there are also moves to have dual isotopes test protocol For instance, you could have thallium for rest and technetium for stress. All right, what are the other ground rules here? Coffee shouldn't be taken 12 hours before so that vasodilatation is not affected. Phosphodiesterase 3 inhibitors like milrinone, etc., and dipyridamole should be avoided for about 48 hours if possible before test to avoid marked vasodilatation and severe hypotension. Use of beta blockers, calcium channel blockers are not allowed if possible for 24 to 48 hours prior to test, depending on the indication for these medications anyway. So how do we stress the heart? Two main types of stressors. We have exercise using the Bruce protocol, and then we also have pharmacological agents. So what do these agents do for us? They're basically vasodilators and positive chronotropic agents. So the vasodilators would directly open up the coronary vessels or test the coronary blood reserve, the coronary vasodilatory reserve. And examples are regadenoson, adenosine dipyridamole. Vasodilators can also be combined with submaximal exercise. The positive inotropic chronotropic agent that's used is dobutamine, and this does its work indirectly. It stresses the heart by raising, the heart rate, and because the heart rate is raised, as happens during stress, the heart is now forced to vasodilate, and we can see whatever effect we want to see. So let's look at the protocol for physical exercise stress. An IV cannula is inserted and kept open, and then we know that there should be no coffee for 12 hours before, and anti-anginal meds and antihypertensives will reduce the utility, so this should not be taken as possible. Patient is put on continuous exercise, the Bruce protocol, and there's continuous ECG monitoring. ECG tracing at every stage of the protocol is done. Peak exercise at the termination. ECG tracing is done at every stage of the Bruce protocol, at peak exercise and at termination phase. Heart rate and BP every 3 minutes, during the protocol and up to the termination phase. And then when we have gotten to the target heart rate, that is 85% of expected for age, and this would be 220 minus age. At 85% of that, when we have gotten to 85% of that, the radio tracer is injected. And then we continue monitoring for another minute before the patient is now put off, taken off the exercise machine. If the heart rate is not achievable, then conversion to pharmacological stress test can be done at that point. So what are the contraindications to dynamic exercise testing? ST elevation MR in the last 4 days, NSTEMA in the last 24 hours, left mainstem stenosis likely to be hemodynamically significant, left ventricular function with failure, with symptoms at rest, recent history of life-threatening arrhythmias, severe outflow tract obstruction, as in aortic stenosis and HOCM. Other contraindications are severe hypertension, recent PE or infarct, thrombophlebitis or DVT, active endocarditis, myocarditis or pericarditis, and patients who are not capable of physical stress. We also have a few relative contraindications, and it borders on severe tachycardia arrhythmias, high degree AV block, electrolyte abnormalities, mental or physical inability, and patients with left bundle branch block and Wolff-Parkinson-White are specifically asked to be scheduled for the vasodilatory pharmacological stress test. So our patient has undergone the physical stress and is now in the gamma camera, has waited, for Sestamibi, you have to wait for about 45 minutes. For thallium, you would put him, in the camera immediately after injection and after the 1 minute wait at peak exercise. And you can see the gamma rays go around the heart and produce an image with a bright yellow showing that The myocardium is well perfused, and the spot that is not perfused as bluish, showing that there is poor perfusion. We'll get to the interpretation much later. Let's look at the pharmacological agents. So we can use adenosine, like I had said before, and of course we use this when exercise is contraindicated or deemed inadequate, when a patient has new onset left bundle branch block or patient is paced. It's a direct coronary vasodilator, and it targets the non-selective adenosine receptors. It has non-selective action on the adenosine receptors. Its half-life is less than 10 seconds, and it's given by IV infusion. So it's got a lot of side effects. Patient feels really terrible, really crappy, feels like they're going to die, chest pain, bronchoconstriction. So this should not be given as much as possible in patients with asthma or COPD. It causes shortness of breath, flushing, headaches, heart block, etc. So let's look at the schema for administration. It's given by IV, the dose of 140 micrograms per kg per minute. It will be given for over 6 minutes. 3 minutes after the injection of the IV adenosine, when the injection is still going on, the radio tracer is injected, and we wait according to the rules of whatever tracer it is that we're using before patient is put into the gamma camera. Now, there are some modified adenosine protocols. In asthma or COPD, you can titrate the dose up, and it said instead of going to the 140 mics, we could start at 70 mics per kg per minute for a minute and see how the patient does. Then we graduate to 100 mics for another minute, and then we can go to 140 for 1 minute and inject our tracer at 3 minutes. Asthmatics can also be given 2 puffs of salbutamol prior to the test, 5 to 10 minutes before the test, and hopefully they should be able to take care of any bronchoconstriction. And if patient has had caffeine less than 6 hours before the test, we can ramp up the dose to 210 micrograms per kg per minute. The next one is regadnosone, also called Lexicon. This also affects the adenosine receptors, but it's a selective A2A receptor agonist. Adenosine bronchoconstriction is mediated via the A2B and or A3 receptors, but this one targets another set of receptors, so it's more tolerable to use when your patient has a history of asthma or COPD. And it's not given per kg, it's given in the 0.4 milligrams that comes in 5 mils bolus, and it's given over 10 seconds, followed by a saline flush, and then followed by the tracer, just as in the diagram. Then we now wait for whatever tracer rules, and we can put the patient into the gamma camera. It's well tolerated in moderate to severe COPD and asthmatics, and there are milder side effects. They don't last as long as what you see with adenosine, but sometimes the side effects can last for up to 30 minutes. The next one is dipyridamole. This is also a coronary vasodilator, and it should not be used in bronchospastic disease. Shouldn't use at extremes of systolic blood pressure less than 90, greater than 200. Is a phosphodiesterase inhibitor that blocks the uptake and metabolism of adenosine. And if you're wondering where this adenosine is from, this is our own endogenous adenosine. We have a lot of adenosine in our bodies. It's infused at the rate of 140 mics per kg per minute for about 4 minutes. And 3 or so minutes after the infusion, the tracer is given. The tracer is given in the dose that's recommended. Heart rate, blood pressure, and ECG should be measured at baseline and every 2 minutes when this is infused, and then the tracer rules are obeyed after it's been, injected in. So those are all of the vasodilators that are used: regadnosine, adenosine, and dipyridamole. But what are the contraindications to vasodilator use? Severe asthma or COPD, it's less so with regadnoson, so that's okay. Unstable ACS, but can be used at 24 to 48 hours after uncomplicated acute infarct. Second or third degree heart block without a pacemaker. Sick sinus syndrome, extremes of blood pressure, dipyridamole use within the last 48 hours, you should look for something else, because then you don't trust the vasodilatory effect, or it's going to be too overdone. Aminophylline or theophylline used in the last 24 hours, you shouldn't use these drugs. Caffeine within the last 12 hours, well, we had the special adenosine protocol that said you could still use it and ramp up the dose to 210 micrograms. And then cerebral ischemia or infarction, this is a relative contraindication. Relative bradycardia, less than 40. We can't do exercise here to increase the heart rate. And then hopefully we should be able to use it. The next pharmacological agent is dobutamine. That seems to be a lone ranger for now. This is a positive inotrope and positive chronotropic agent. It will increase the cardiac work and therefore force the heart to vasodilate on its own. It's a synthetic analog of dopamine. It's a very potent agonist of the dopaminergic agonist, alpha and beta agonist, but it doesn't have the dopaminergic effects that we don't want. So half-life is 2 minutes. It has a dose-dependent effect, and it's very useful when patient cannot exercise and when vasodilators are contraindicated. We kind of go through the back door and see if the heart can, vasodilate. For this medication, we have to stop beta blockers 48 hours prior, or we will not be able to get the heart rate up, because this is what this medication depends on. And as part of this protocol, atropine can also be given in those who don't reach the target heart rate. We can give atropine at the dose of 0.3 to 0.6 milligrams up to 1.2 milligrams total. And this is given at every stage that I'm going to explain. You see, dobutamine is given in incremental doses. So for every 3 minutes, we start at 10 mics per kg per minute. And then we go the next 3 minutes, we go for 20. And then the next 3 minutes, we go for 30. And then by the 10th minute, we should be giving the last dose. And hopefully we should get the heart rate, that's a 40. Hopefully we should get the heart rate at 85% of what is expected for the patient's age. It is at this point that the tracer is injected, and the test is ended about a minute after the tracer is injected, and patient is sent to the scanner depending on the rule of the tracer again, immediately for thallium and 45 minutes for Sestamibi. So what are the contraindications to dobutamine? It's basically the same as for exercise. In hypokalemic patients, we shouldn't use it. When patients have a left bundle branch block and patients that are paced, we should use vasodilatory, pharmacological agents instead. So what happens with image acquisition? So we have we've given the tracer, and then we wait and obey the tracer rules that I had said. Technetium is 45 minutes and immediately for thallium. And then we put the patient under the camera. It's usually about 20 minutes. And there's something called ECG gating that's done, at the back end with the computers. And these are techniques done to improve the temporal resolution of the images, because the heart is constantly in motion, and gating helps to improve and capture these changes in real time. Images are interpreted visually as well as quantitatively. So let's look at the interpretation. Let's start the interpretation proper. So we look at slices of the left ventricle, for obvious reasons, as the seat of contraction of the body. And we're going to look at slices that are short axis. These look like donuts. We'll also look at the vertical long axis view, where the cut is from left to right. And we'll look at the horizontal long axis view, where the cut is from top to bottom. And these are splash images of what is expected. So with splash images, the stress panel is on top, the rest panel is below. and this would be for the short axis, these ones that look like donuts, and then the VLA and the HLA. And then you also have what is known as the polar plot, or the bull's eye, or the target plot. These I consider summary images. And if this is it, and if this is all you have, when you're looking at the short axis and the VLA and the HLA, the stress panels would be in this long line on your left, while the rest panels will be this long line on the right. Let's dig a little bit deeper into the polar images. So the polar images are generally superimposed on the American Heart Association 17 segment cut of the left ventricle. So you can see here that in this yellow, this is at the base of the heart. It cuts the heart in a counterclockwise section into 6. The mid section, which is in fossa, cuts the heart again into 6 sections. And then you have the basals, so we have the apical section that in the blue that cuts the heart into 4 segments, and then the apex, which is usually at the center, cuts the heart, just leaves the heart with the 17th segment. And of course, we appreciate that the top is the anterior, the bottom is inferior, to the right is the lateral, and to the left is the septal. This says about the same thing. It's just that the polar plots are coming out here, and we can see, the superimposing of the segments onto the polar plots better here. So this image shows us very kindly the blood supply as we go over the polar images. So on the lateral on my right, which is supplied by the left circumflex from about the 1 o'clock to the 5 o'clock, it's a lateral beat supplied by the left circumflex. We come to the inferior segment from 5 o'clock to 9 o'clock, which is the inferior beat supplied by the right coronary artery. And then from the 9 o'clock to the 1 o'clock back up is the septum to the anterior, parts of the anterior, supplied by the left anterior descending artery. And this shows us what direction or what vessels should be targeted when we get these images out with the polar images. This just says the same thing, but I just wanted, another picture that's representative of what we just talked about. Now let's continue with the interpretation. So before we interpret this, we have to take note of the color coding. The yellow or the bright color shows that there's good myocardial supply and therefore good blood flow, while the blue shows that there is stenosis. And let's try to see what this means. So if we start from the rest image, we can see that there's good blood supply, generally with the rest image, which is good. And then we go to the stress image, we go to the left-sided panel, and we notice that, yes, the heart can really dilate the coronaries. So that is excellent. This is a negative result. We don't have any issues. But what if there's a stenosis? We look at the rest, the rest panel again, midway. That is normal. But when we get to the stress panel, we notice that there's a portion in LAD here, in LAD as indicated here, the LAD section that is blue, that is not lighting up. So that shows that this area should be targeted for intervention. But what if you have two pictures that show occlusion, both at rest and at stress? This is what we call a fixed defect, and we'll come to that much later. So we have talked about this normal picture where you have the rest panels being the same with the stress panels and the short axis, the VLA and the HLA. This is a normal panel, normal results, and we're all happy. I just thought to bring this up because the A picture was taken in a 2-day protocol, and then the B picture was taken in a 1-day protocol, and these both of them are very interpretable and look very good. So this is also normal with the polar image. You can see that the polar image is almost the same as this one. The blue, it's really minimal, and there isn't any issues. Stress is the same as the rest. But when we look at this one, we look at the rest panel, that's the one that's underneath, in the middle. And then we see that This blue seems to be bigger when we stress the heart. Now, this shows that there's stenosis here. This is a positive result, and this is reversible ischemia, and this must be targeted. This is more in the region of the RCA, and this must be targeted for intervention. This is a positive result. We now go to the fixed occlusion. Here you can see that both the rest panel and stress panel have the same defect. In fact, you can superimpose. You can literally superimpose the rest on the stress panel and it will just be the same. So this is what is known as a fixed perfusion defect. And it's said to be due to scarring or fibrosis when it is severe. So the nuclear radiologist will quantify it, how severe it is. And if it is a severe defect, then it's due to scarring or fibrosis and does not need intervention. However, the reason it doesn't need intervention is because patient has most likely developed collaterals and has learned to exist with his occlusion. So you really don't need to intervene here. However, when there is a mild or moderate fixed deficit, fixed perfusion defect, it could be due to a hibernating myocardium or a prior non-transmural myocardial infarction. And in this case, patient needs to be worked up because patient may need intervention beyond the goal-directed, medical therapy to make sure that this is reversed. So depending on the results we get, the interventions are, directed at such. So a severe fixed perfusion defect does not need intervention. And this is due to scar tissue or fibrosis with good collaterals, while a mild to moderate fixed perfusion defect, as determined by the nuclear radiologist, is going to need some more workup and some more intervention beyond just mere pharmacological agents. So guys, we've come to the end of today's transmission. Thank you so much for hanging on and listening to this rather long transmission. Please like and subscribe to my channel and put your questions down, and I'll visit the channel and answer your questions as they come in. Thank you so much again.